he have stroke? Adam wrote it.
So is he still in the program at all?
So, yes and no. He is the emergency management for St. Francis and for St. Joe's. He wanted to stay on teaching. I was okay with him teaching the Con Ed at night for the unaffiliated people, because then I don't have to work nights. So I was okay with that.
Did you take his job then?
Yes.
Oh, cool.
Yes. Yeah, so,
But you're sticking with us?
yes, yes.
Are we your only department?
No, I'm gonna keep Evanston too.
Super lame.
They don't want anybody else either, so we,
What do you care what they think? I mean, you should care what we think, but.
I do care, that's why I'm staying with you.
Nice.
So, you know, I could bring Adam back and ask him if he'd come here for you guys, you know.
No.
That's right.
So, yeah, so he's still teaching, he teaches the unaffiliates at night, so that's good. And then Captain Steve Jagman, he is the EMS coordinator over at Skokie. It was their month to put the Con Ed together. So, a little bit different than last week's Con Ed because I went back and rechanged a lot of things as part of it, so we'll, let's fix
He what? He's the EMS guy now?
Steve Jagman,
Yeah?
yeah. Gabe Millard used to be.
Yeah.
And then I think Gabe, I don't know if he got some type of promotion, but then he gave it to Steve.
Really?
So
Interesting.
they've been doing a lot of changes there too over the last year, you know, with the chiefs and everything else like that. I think their chief, Jeffrey Horlick, is still interim. I don't think they've hired a full-time yet,
Okay.
so. But yeah, unfortunately, he's not much into the education aspect of it, so we'll see. Trying to get Skokie a little bit more involved into the system, and really honestly, that's my goal as the new coordinator, is to start pulling the departments in to have more of a say within our system versus what was done in the past. You know, I think it's important that you guys are out there, you're doing it, have a say what's going on, what works, what doesn't work, because there's no sense someone like, you know, me sitting there pushing a pencil and then coming out and telling you guys this is the way we're going to do it when it may not work. So I want to have more involvement within our departments. So, all right, so I know, just as a reminder, we do have to do stroke once a year because of our affiliation and being a primary stroke center. We're going to talk a little bit about some of the various stroke centers within our district too. So, when we take a look at strokes, yeah, strokes just can happen for whatever reason, but they usually have some underlying issue. And a lot of the different things, according to American Heart, stroke is listed as now the 5th leading cause of death in their whole listing. You know, and they start off with obviously heart disease and cancer is a big one. This year they actually added suicide just due to the increased number of suicides out there that are now in the top 10 for leading cause of death. Some of this information a little bit older. I know this was in 2016. Still to this day, this is the way it's listed. It hasn't really changed a whole lot. Talking about different types of people and who is more prone to have a stroke. Women, there's one thing about women and having strokes is that they have other things that are underlying factors. Pregnancy, you know, you can have embolotic type strokes or from the amniotic fluid. Young women who are on birth control pills and that maybe smoke, they're more prone to having some type of clots. You know, and there's other things out here too. Women who go through menopause and then have to have hormone replacement therapy, you know, are also more prone to having strokes and some of the other medications that they take. So we do see women as being very common. Now when we take a look at the different ethnic groups, the black ethnic group is 57% more likely, whereas the lowest one is Native American. Caucasians are at about 41% more likely to have a stroke for it. So the other thing we look at is the different types of symptoms that we see and their risk factors and what kinds of strokes that they have. So a lot of different ways that we can end up people can have stroke. So here's just some of the statistics that come down from American Heart Association. American Heart just updated their guidelines. We see them 2019, 2018, which right now we are working to put these new guidelines into our protocols. We are trying to keep our protocol book as live as possible. And I think one of the guys last week had asked about having new small books. We're not going to be printing new small books, but what we're going to do is we've talked to Martha about printing like a sticker or something that they could just put on over the pages of the books and the small books until we go ahead and actually print new ones. It looks like we probably will be printing new ones after this round because there's going to be quite a few changes again. Someone has a stroke about once every 40 seconds in the United States, and we know that someone dies from a stroke once every 3 minutes and 45 seconds. So with our strokes, it's not just the impact of having a stroke and having it being overcome. People have long-term impact. I talk about a dear friend of mine. He was a Waukegan firefighter, and he was underneath one of the fire trucks working. Someone thought it'd be funny to turn on the siren, and he turned his head real quick, and in his carotid arteries, he had some plaque that broke loose. And he ended up having a posterior stroke, which had a long-term impact. Obviously, he had to retire on disability, but he walks with a cane. His balance is terrible. He has problems swallowing. He's got long-term and short-term memory. And so things from strokes, yes, we see some people that do go ahead and recover just fine, but some do go ahead and have long-term effects. The biggest one being depression. You know, they talk about anything, whether it's from chronic pain to strokes to cardiac issues. Depression seems to be one of the big things that people suffer from a lot with a lot of different medical conditions. And so more and more people are being treated with depression and being on medication, because we do know that as we go through it, you suffer all the time, and it does kind of wear on you and brings you down a little bit. Aphasia, being able to communicate is a big one. Whether they're still slurring their words, whether they can't remember if something, like, you know, bring me this, and they can't remember that this is a coffee mug. You know, different words. They may suffer from hemiparesis or even weakness on one side of the body. And they can't walk without some type of assistance, so they may be, you know, using some type of a cane. So we take a look at the different types of stroke. We have hemorrhagic and ischemic, breaking it down into those two main types of strokes. We know that ischemic strokes are about 87%, well, 80 to 87, that's kind of changing a little bit. And hemorrhagic is about 15 to 20% more likely of those types of strokes. There's other ones, cryptogenic type strokes, and I actually have to remember it's kind of a strange type. It's mainly that with the cryptogenic, they don't understand what caused that stroke. It just kind of happened out of the blue. We can have brainstem strokes, which are another one, and then those are all part of the ischemic type of stroke that's out there. So first of all, years ago, when we looked at people were having a stroke, we didn't really know, was it a hemorrhagic or was it an ischemic stroke. It was just, we knew they were having a stroke. We were very cautious on the medications that we gave them because we in the field could not determine. Now, based on the types of signs and symptoms that we're seeing with the types of strokes, we're able to identify, is it a hemorrhagic, is it ischemic? We can even go to say, is it a large vessel occlusion stroke, or is it a posterior stroke? And by learning the signs and symptoms will help us get these patients to the facilities that they need to be able to identify and treat them accordingly. Now, with the ischemic stroke, we go back to something we know, the Cincinnati Stroke Scale. We take a look at the face. Is there drooping? We can ask them to smile. Do we see the drooping? Have them stick out their tongue. If their tongue deviates to one side, we know that's one of the ways of having another side of a stroke. It could be a warning sign. Take a look at the arms. We have them put their hands out. Make sure they're closing their eyes so they don't cheat. Have them try and hold for 10 seconds, and if one arm drifts. What is their speech problems? Now, more than likely, with the ischemic stroke, we're going to have problems with slurring of the words. Not so much with, right and left hemispheric strokes can identify, but can they identify that that's a mug or this is a table? Sometimes that gets they get rather confused. And then T is for time. What is the time to call 911? That's what they use for pre-hospital or public education. But we in the field look at T as what time did the signs and symptoms actually start? That's what we're looking at. The other things too, we're looking, can they move one side of the body? Do they have trouble walking? Are they lightheaded, weak, and dizzy? Are they unable to understand speech? Those types of things all lead up to that they might be having some type of an ischemic stroke.
Question,
Yes.
are they not really doing hand grip anymore? Right?
No, no hand grip anymore.
So it's
Yeah.
just what? Just,
Putting the arms out, closing the eyes, 10 seconds, does their arm grip. We don't have them check for equal grips. And the reason for that is because a lot of times the elderly with arthritis in their hands, they're not able to give a good solid grip because of arthritis. So yeah, good question. But yeah, we're using the arms instead. Now, depends on where that stroke actually is within the body. Can be really affect different things. I mean, if it's down here, you might be looking at affecting swallowing or having them stick out their tongue. In here, you're looking at problems with the different fingers. Over in this area, could be the foot, the hand, or the foot or the toes. So, I know that's not the best picture, but it really looks at parts of the brain affect different areas of the body. So when we look at ischemic stroke, there's a couple different types. One, we can have a main clot that gets, like a thrombus, like someone having AFib. And in the atria, clots are building up, and then all of a sudden one will kind of let loose and go into the system, and we have a blood clot of some type. Someone who's had DVTs, pulmonary emboli. Someone who has been sitting for a long period of time, and blood starts to go ahead and kind of clot, and then that throws clots. You can have areas where plaque is actually built up, and at that point in time when plaque builds up, if you remember the whole clotting cascade, there's damage there. So the body sends these red blood cells and platelets to kind of get sticky in that area to kind of fix it, and then it sends fibrin, and it starts to make more and more, and it gets bigger and bigger until it occludes this whole vessel. That's another different type of clot. You can have emboli such as amniotic fluid that might be, air embolies. There's various different things that are going to cause some type of an occlusion and not let blood through. So that's what we're looking at. You can also have, we talked about the narrowing with it building up until it finally occludes the area. But when it does, you're not getting blood flow on the other side. And the area that we're looking at is called the penumbra. This is the area that we are looking to fix when we go ahead and we're trying to help someone with a stroke. So you have the area, this area right in this small here, that does not have oxygen. That's where the clot. That's the area of infarct. But as time goes on, the penumbra area gets larger and larger because you're not getting oxygen to those various parts of the brain. Now, the brain is really great because it has a lot of collateral circulation. So if we do know at this area here, there's an occlusion, blood flow is going to kind of go around it or come from other areas to get the blood it goes. But it's not going to be enough to sustain that brain tissue itself. So what we're trying to do is get rid of that clot early so that blood flow gets to that main area of the penumbra and that area can be saved. Yes, the area of infarct, that will die, and there's nothing that we can do to go ahead and fix that. Now, when we talk about ischemic strokes, and people come into the hospital, we want to give them, if we can, if they qualify, TPA. We talk about TPA as being liquid Drano for the vascular system. If there's a clot in here, it's going to dissolve it, and it's going to get blood flow to those areas. But there's other types of strokes, like one being the large vessel occlusion. And this is treated a little bit different. They'll do coiling, they'll do, where they'll suck it out, they'll break it out. TPA doesn't work on every single type of clot. It depends if there's fibrin that are holding that clot together. Because it's an antifibrinolytic, it breaks down the fibrin to kind of separate all those blood cells and let them break down and blood flow to go again. It's not going to work on an embolotic type stroke. It's not going to work on an amniotic fluid or an air or, you know, something that's not clotted with the fibrin. When we look at it. What's really nice about these is we can actually start to figure out if it is a large vessel occlusion. City of Chicago is actually doing a new study, and they're using a special score that they look at to identify large vessel occlusion. And if they see a patient having a large vessel occlusion, they will take them to a different type of stroke hospital, more likely the comprehensive, to be able to get them the treatment with the interventional radiologist. So, when we recognize a large vessel occlusion, we're looking at using another score. It's called a GFAS. One of the things you'll see with large vessel occlusion is that the eyes will deviate to one side. Now, you may ask them to go ahead and follow your finger, and they can do that, but once you take that finger away, the eyes will actually go back to gazing in the other abnormality, kind of like with them. We still use the face, asymmetry, arm drift, speech difficulty, and when did signs actually start to occur. Now, the other thing we look for too is the posterior circulation. The posterior portion of the brain, or the cerebellum, that's responsible for our fine motor skills. And what we use is, can they touch their nose with the tip of their finger to identify posterior circulations. Now, with these patients with large vessels, we try and get them there within 4.5 hours. I know that's kind of stretched out from the 3 hours that you guys are used to knowing about, but we can go up to 4.5 hours to be able to get TPA. But what's nice with the large vessel occlusions is that we can even go further out up to 12 hours, 8 to 12 hours, that patients can go in and have some of these vessels actually rotor-rooted out. You know, we can break it up, we can go ahead and coil it, and I've got some videos that'll show it to you, so you'll kind of see that. With our posterior circulation, or posterior strokes, these are strokes that people miss a lot of times because they're not necessarily showing the big signs and symptoms. We might suspect that they're a TIA. Blood pressure is initially like about 140/90, a little bit higher. They have loss of vision, blurred vision, double vision is a big one for patients with posterior. They might, I kind of attribute it to someone who has their foot nailed and they kind of keep going around in circles because they can't move one side. They're bumping into things. Their spatial awareness is kind of off with some of these patients. They feel like they're being pulled in one direction. They can only walk that one direction. So with these patients, we can say, oh yeah, they might be having that posterior stroke. Brainstem, if they're having one of those, we have cranial nerve abnormality. Usually it's going to be unilateral. It's not going to be both sides. It would just be the one side. They have the doll's eyes, or the gaze that goes off to one. Eyes don't necessarily move. They can't really swallow very well. They have cross-exam findings. Numbness of the left side of the face, but then the right arm or the right leg is not working like it should. And then those are all things that are going to identify posterior circulation. Other things too, they're dizzy. They have problems with focal points, neurological focal points. So, and like I said, if you can go ahead and have them take and try and touch their finger to their nose, if they can't do it, because that's part of that fine motor skill, they're probably having a posterior stroke. Now, hemorrhagic strokes, our signs and symptoms are a little bit different. They're a little bit more, drastic. These patients will have that thunderclap headache, the world's worst headache in the world. They get the double vision. They have the projectile vomiting. And when we break it down into the two different types of hemorrhagic stroke, you can have the subarachnoid bleed, which is mainly up here on the surface, in between the arachnoid space and the skull, the dura mater area. Or you can have one that's deep down inside the intracerebral area. The subarachnoid, we can usually do something about. We can't do something about the intracerebral hemorrhage. These patients will usually have to have brain surgery. They'll bring someone in, and a neurologist, an interventional radiologist, and they'll go ahead and try and repair some of these vessels with deep in the brain. Now, other signs and symptoms too can be trouble speaking and understanding. One thing that's really important for you to remember with people that are having strokes, especially the hemorrhage, they may understand what you're saying, but they just cannot get, they can't get you to understand what they're trying to say. And they get very frustrated. And a lot of people say, oh, because it's, a head injury and there's intracranial pressure, these patients get combative. They don't get necessarily combative because of the fact that, yes, there's increased intracranial pressure, but most of the time, it's because you don't understand what they're trying to get across, and it gets very frustrating for them. Make sure you're showing, some patience with these types of patients. So yes, they will have trouble speaking and understanding. They might have paralysis to the face, the arms, the leg. They have blurred vision, double vision. Their eyes may, again, deviate. The sudden headache is very common. Vomiting, altered mental status if they're having a stroke, and then yes, they may stumble or loss of balance. And again, that goes back to that posterior type of stroke. So when we look at our hypertensive emergency, and I know that we will look at the stroke protocol here in a minute, but with patients who are having hemorrhagic strokes, they get that Cushing's triad: elevated blood pressure, decreased heart rate, and erratic respirations. And so their blood pressure becomes so high, we think, are they really having a hypertensive crisis, or are they actually having a stroke of some type? We look at our hypertensive crisis, we look at our vital signs. BP greater than 220 if it's systolic, diastolic greater than 120. It doesn't have to be both, it can be one or the other. Okay? Some of the other signs and symptoms we see with someone having a hypertensive crisis: blurred vision, nosebleeds, neurological changes. With these patients, we're going to go ahead and do our routine medical care. There's not going to be a whole lot we can do for patients that are having hypertensive emergencies, because it's really hard to determine if is it a stroke or is it just high blood pressure. Because we can give nitro here, but more than likely, medical control is going to be a little reluctant to go ahead. We know that if someone's bleeding the brain and you go ahead and you give them nitro, it's going to dilate those vessels, it's going to make them bleed worse. The other thing is that if we have, as we dilate the vessels, it can actually move that clot along too into a little bit tighter area, which we definitely don't want. We make sure we take blood pressure in both arms. We can see, are they having some type of aneurysm? Some type of aortic aneurysm, whether it's ascending or descending for these patients. But if we have differences, that's something really important to know. But when you call into medical control with these patients, keep the lights down low for them, probably no lights and sirens. We don't want to increase the risk of having seizures, and a lot of times let them be in the position of comfort. So with our nitro here, I just want to talk in general with the nitro, because we do use it for various things. We use it for heart failure, we use it for hypertensive crises, we use it for ACS and chest pain. How many of you guys are aware? Oh, let me ask you this. So you go ahead and you have a patient who's experiencing chest pain today. Let's say 8 out of 10. And you get there and you bring in your monitor, you give them aspirin, you run a 12 lead, you say, okay, it's not an inferior wall. Can you give that nitro to them without starting an IV first? I can tell the younger ones, or the newer medics, because yeah, some of the older medics are still like, oh, nope, have to have that IV before we go ahead and give nitro. And that's what we've always taught because of the fact that if they bottom out their pressures. But now that we have the ability to look at the 12 lead and recognize that it isn't an inferior wall MI, we can give the nitro. Now, you still have to start an IV, but it doesn't have to be before you give the nitro. We've had some people asking, and I don't know, we'll just kind of throw it out here for discussion for you guys. Would you guys rather have the spray or the tablets? Or doesn't it really matter to you?
I think it matters a ton, but the spray's probably a little bit easier for a patient and some, you know what I mean?
Okay, well, and that's what I hear. I mean, there's so many pros and cons, and personally myself, I think this is something we'll bring up at our advisory council, which we want to switch to. You know, because some people say, oh, the tabs, you know, they're such a problem, they're so small, they fall all over. They would rather have the spray because it's easier. The only thing, and I'll be honest with you, the spray lasts a lot longer than the tablets once it's open. The only problem with the spray is getting that vial up against someone's mouth is close and then having to go ahead and use it on another patient. So, you know, honestly, I don't know why you couldn't just wipe it down with some alcohol or something like that. But, yeah, I don't know. It kind of goes back and forth, and we've been having people ask in the system to switch over to it, so it doesn't matter to me, really. Big thing we have to watch out for with the nitro is that they're not on Viagra, Levitra, or Cialis, knowing that it can be up to 24, 48 hours before that they can have them. Here's the one thing, in all the studies with this, we tell you this all the time, just as a sidebar here, it doesn't drop the pressure all that much. You know, if you've got an IV established, you can go ahead and a lot of times administer it up to like after 24 hours, and it's really not going to go ahead and drop pressures a whole lot. The other thing you have to remember, the half-life of nitro is not that long. It's about 5 minutes, and then, yes, pressure may drop, but it's going to come right back up. So, we're pretty good with that. Other things that nitro does is it's going to decrease preload. It also decreases afterload. It decreases oxygen consumption, so that if someone's having chest pain, it'll dilate those coronary arteries. Hopefully, blood flow it'll open them up to allow blood to flow. It decreases the oxygen demand in the heart, so if someone is having an MI, it's not going to, it's going to be a little bit easier on the heart as far as using it. We use the blood pressure at 90 systolic. Even think about if you have a patient who's having an inferior wall MI, and their pressure's high, I'm not saying real high, but maybe like 130-ish, 140-ish, over even 80 to 90. Talk to medical control. They may actually even order the nitro in an inferior wall MI, just because the pressure is up there. Usually with an inferior wall MI, though, you're going to see blood pressure be a little bit down, hypotensive. They'll actually, at the hospital, go ahead and give them a liter of fluid first, and then they'll actually put them on nitro. If you have time and you're transporting long distances and you've given them 3 nitro and you still say maybe you have 10 minutes to transport and blood pressure's okay, ask medical control if you can go ahead and give some more nitro. We want to continuously give nitro if we can until we get to the ED where they can actually put them on a nitro drip, which will be consistent then. But yeah, don't feel bad about saying, well, I've given my 3 nitro already and I still got 10 minutes to transport. Medical control vital signs are still good. And they're still in some type of pain. Can I go ahead and give them 1 more nitro? Look for patients in nursing homes if you have them. I know that you don't have a whole lot of nursing homes here, but making sure that they don't have nitro patches on before you go ahead and give other nitro. Alright, TIAs. TIAs are, sometimes people call them mini strokes. People will go ahead and be fine one moment, and then have some signs and symptoms, and then they go back to being fine. They usually define TIA as stroke-like symptoms that will resolve themselves within 24 hours. Now, we are not going to wait 24 hours to see if these signs and symptoms resolve themselves, but they can actually determine them or at the hospital if they go ahead and have a TIA or something some other type of strokes. We do know that people that have TIAs are just the prelude for the big ones. Some of the other things that we need to take a look at. What is a stroke mimicker? I always use, I said, my mistake, and I've learned my lesson on it. When I was working, we go ahead and we fly a lot of our strokes up to Milwaukee. And I had an elderly gentleman, and I was bound determined this guy was having a stroke. And I'm like, okay, I'm gonna land the helicopter, we're out in the country, I'll have fire set it up over in the field. Everything was going just as I had planned it, and got the patient loaded up, took him up to Milwaukee, and I was feeling pretty good about myself until I got a phone call later the next day saying that the patient had, did I do a blood glucose check? And I'm like, I don't know, did I? Well, the guy had a sugar at 28. They ended up giving him some couple amps of D50, watching him for a while, and sent him home 4 hours later with a $1,700 bill for flying up in a helicopter. So it's really important when you're dealing with something that can mimic a stroke that you try and take a look at all the other possibilities and kind of rule them out first. That's really important. Don't try and get that tunnel vision. And that's what I try to teach all the students, that when you're looking at something, always ask, why is the patient behaving the way they are today? And not only why, but what are all the different things that could be going on with this patient? And start asking your questions to rule them out. So if we take a look at hypoglycemia, I take a sugar right away. That's a quick, easy way to determine if someone's having a stroke or not. Not saying that someone can't be hypoglycemic and having a stroke, but are they postictal? Did they have a seizure? Do they have migraines? Multiple sclerosis? Do they have some type of neoplasm? You know, some type of tumor going on? Meningitis? These are all different things that can mimic a stroke. How about Bell's palsy? We know with Bell's palsy, and there's some slides coming up that Adam put in here, but it does look like they're having a stroke on one side of the face. Drugs and alcohol, trauma from head trauma itself, and then just even hypertensive encephalopathy. These are all different things that we need to kind of weed through to see, are they really truly having a stroke or not. Bell's palsy, as we were talking about, affects the 7th cranial nerve, and it does make someone look like they're having a stroke. It's usually some type of infection of that 7th cranial nerve, but it's very easy for you guys to make the determination if they are having a stroke or if they have Bell's palsy. And that's have them lift their eyebrows. If they can lift their eyebrows, it's not Bell's palsy, it is a stroke. But with Bell's palsy, they can't lift that eyebrow at all. And when you take a look at the comparison between Bell's palsy and a stroke, you know, likely or possible, yes, facial droop, speech difficulty, inability to furrow the brows, likely if they're Bell's palsy, not likely if it's stroke. Some of the other things, ear pain, TMJ, Bell's palsy, yes, not likely if they're having a stroke. Inability to close the eye on the affected side. Sometimes patients with Bell's palsy will actually have to pull down their eye, and it's constantly tearing that you see, excessive tearing with these patients, if it's Bell's palsy. Just looking to see some of my, I don't know where some of my videos went to. Pediatric strokes. Yes, peds do have strokes. Now, interesting with peds, the more common type of stroke is going to be your hemorrhagic stroke versus the ischemic type stroke. We see the ischemic type strokes mainly in our older patients because of all the chronic diseases and the other things that could be going on, like AFib. Pediatrics a lot of times will have weakening blood vessels in their brain, which will go ahead and rupture, causing them to have a stroke. What they're looking at is here in the ischemic they'll have normal, but in hemorrhagic you can actually see some type of a bleed occurring within on the stroke side. So we do see quite a few of them have some type of strokes. What's nice about pediatrics having strokes, and if anything's nice about it, is that they recoup very quickly. We don't see the long-term effects like what we see with our older patients. The only problem is it takes longer for us to identify if a peds is having a stroke, because we don't expect them to be having a stroke. So, yeah, and they have in a worse acute period of the stroke, but then the long-term effect is much better, so. Alright, so we're getting ready to assess our patient. Very important for you guys to know, when was the last time they were seen normal? When did signs and symptoms actually begin? And making sure that's being documented in your report. Our stroke coordinator, she looks for that all the time because it's going to help her identify what type of treatment the patient actually may have. We want to make sure we're checking that blood glucose level to make sure that it's not something hemorrhagic or something hypoglycemic. Take a look at the past medical history. Do they have a history of AFib, DVTs? Have they had recent surgery? Have they been traveling and been on a plane for a long period of time? Those are all questions that we want to know, because we're starting to rule out all of those mimickers that we were seeing. When's the last time they did any drugs or alcohol? We want to do our Cincinnati stroke scale. Take a look, have them smile, have them raise their eyebrows, furrow their brows. Have them check their arm drift, close their eyes. Again, remember, we want them to close their eyes so that they're not trying to cheat the system if they can. They won't realize that one of their arms is drifting off if they have their eyes closed. What is their speech patterns like? Have them say something. You can't teach an old dog new tricks, or even just listening to them. Something with a lot of S's in it is really good, because S's people have a tendency to slur. Do they get the words mixed up? They're trying to say, well, I need you to sit down at that desk over there. They don't know that that's a table. You know, that's what we're looking for. Anytime we have one positive aspect of this Cincinnati stroke scale, it's a 73% chance that they're having a stroke. This is the BFAST. Now, American Heart hasn't necessarily grasped on to BFAST yet. There's a lot of other agencies that are using this, mainly for public education, as a determination if a patient is having a stroke. Balance being one of them. Are they unable to go ahead and maintain their balance? You know, are they bumping into things? That can indicate that posterior stroke. Taking a look at the eyes. Loss of vision in one eye, blurred vision, double vision. And then, of course, we go back to the FAST part, which we've talked about all along. And again, for us providers, instead of calling 911, we can say, when did signs and symptoms actually start to occur? We take a look at the eyes. Are the eyes normal? Are both pupils dilated? If they're both pupils dilated and non-active here, non-reactive, it could be that we have some type of brainstem injury. Be looking at a brainstem stroke. Or are they are they reactive? If they're able to react but they're dilated, then we can say, yeah, generally we can reverse that. But by the time someone's pupils usually dilates, it's too late for us. Do we see, you know, one of the eyes going off to the south, one of the eyelids? You're looking at maybe your third cranial nerve. Could be an issue. Do you have a pupil that's one's larger than the other? Unilaterally dilated. It could be that we have increased ICP occurring. Altered mental status. And then when we talk about non-reactive, we see ICP, and non-reactive with normal LOC, it's usually not from a head injury. So we take a look at these pupils and make sure that we're identifying with them. Take a look, is the face symmetrical? You know, you look at here and she's able to go ahead and her face goes up just fine, but we see drooping here. Can we wrinkle the forehead? Do we have a problem with that 7th cranial nerve? You know, when we go through and we teach all the students all of the cranial nerves and the tests that go along with it. And we say to them, do you guys do a cranial nerve test on every patient? And they're like, no, we don't. They really do, based on a lot of the different things and how you assess the patients. All right.
Lady Antebellum was the big winner tonight with 5 Grammy Awards. Rapper Eminem, the big shocker, winning only 2 despite 10 nominations. CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy rotation tonight. We had a very Darrison, but let's go ahead, Terrace Chase and look for the head of the pit. We had a very...
So, speech. She actually, with this, they thought paramedics thought that she was having a stroke. She actually had a sudden onset of a migraine that came on that actually affected her speech. When she started off here though, she didn't realize that she was talking gibberish. It wasn't towards the end that she was having an issue, that she was trying to get them to go back to the studio and off of her. But sometimes they have a hard time understanding or getting the words out, and they don't make a whole lot of sense. Taking a look at the arm drift, palms up. Is one arm kind of falling off to its side? Could it indicate that they're having a stroke? So some of the things that are going to cause you issues with assessing is that a patient may have had past strokes and, they have some type of residual effects. They might have dementia, Alzheimer's, trouble speaking, trouble swallowing. So it might be difficult for you to understand or be able to get the history from them. They might have eye issues that are causing the problems. Take a look at someone who's got glaucoma or cataracts can be some type of concern. Maybe they just are generalized weak, their knees hurt, and so they're walking with a cane. They have a loss of balance or coordination. So we do have to go through the whole assessment with them, but understand what their past medical history is, and do they have any of these issues that might be concerning. So I was telling you earlier that Chicago, and yes, I sent Adam the slides that Chicago is using for their training. So he pulled some of them because some of them are really good. But part of the new CFD is that they are doing that finger to nose test. We do know that strokes in the cerebellum will have acute valence problems, or they can't touch their finger with their nose, or touch their nose with their finger. If they do it nice and smooth, then you know that it's not going to be a posterior. But if they're having problems and they're trying to get it, or they can't necessarily hit their nose, then we need to assume that they might be having some type of posterior stroke. This is just some more statistics that they added in, but bottom line is when we take each stroke that a patient has can accelerate a life up to 36 years. When we talk about what is our health age versus what is our actual age. Even every time that the brain is without oxygen, it can accelerate our aging by about almost 9 hours. So this is our stroke protocol. We start off with our routine medical care, making sure we find out what time that the patient started having signs and symptoms, last known well time. We used to not be able to do anything for a patient if they woke up and all of a sudden they couldn't walk or they were having signs and symptoms, because we didn't know, did it happen right after they went to bed or right before they woke up. What's nice about the new treatment processes out there is that we can still do something for them if we don't necessarily know that in last known well time. Then we want to do a blood glucose. Everybody's like, well, we should do Cincinnati first. A lot of the times you can do both at the same time, but get the blood glucose, because remember the oxygen need, or the brain needs blood or oxygen and glucose. And if they are hypoglycemic, less than 60, we want to go ahead and get them the glucose. Now, if you look in your protocol book, on the back side of the protocol book where all the medications, they talk about bleeds within the brain and not giving dextrose to these patients. And so that was something that years ago we used to teach people too, that if someone was having a brain bleed, you didn't want to give them D50 because dextrose causes tissue necrosis. And so it was going to cause brain necrosis if that dextrose got into the brain. Think about it though. I put dextrose in my arm. It's got to go up through my heart, into my lungs, back through my heart, up and out, and by the time it gets to my brain, it's already, a lot of it's been metabolized already, and it's already been diluted enough that it's not really going to cause any necrosis within the brain. Can't get an IV established, we also have glucagon. Perform that Cincinnati stroke scale. please let the hospital know as soon as you can. Give them a stroke alert so that they can get their team in place. And then, take a look at what other, I mean, here's our stroke scale, but do we have neurological deterioration? Headache, unequal pupils, one side one side a little bit weaker. With these patients that we suspect that they may be having a hemorrhagic stroke, we want to get them intubated as soon as possible. Take over that airway and ventilate them. Remember, oxygen causes vasoconstriction and CO2 causes vasodilation. We want to ventilate them fast enough that it's going to decrease the blood vessels, but not so much that it clamps them down that we're not getting any perfusion within the brain at all. We're going to bag them one breath every 3 to 6 seconds, but we're really looking to keep that end tidal at that low end of the 35 to 45. Traumatic Brain Injury Foundation really talks about 33 to 35, and if you're ventilating someone, keeping them at 35 is probably going to be sufficient. It's going to allow the brain to still have enough perfusion pressures in it, but yet slow down some of the bleeding within the brain. So, how about starting an IV on stroke patients? What do you think?
Give it a look.
One try.
Yeah.
Give it a look? Can't? Then don't. Yeah, I don't want you guys to keep making them into pin cushions. If you've got a nice big vessel and you know you can hit it, great, hit it. But if you're like someone grandma, they've got real small little spider wings, we don't want you to keep poking, because if they are a candidate for TPA, then they're just going to bleed from all of those sites. You want to go ahead and, we go back to the fact of the risk of infection pre-hospital, but for a stroke, fluids are going to do nothing for them. It's not going to help them. It's only IV access if they would go ahead and go down the tubes very quickly.
We had a guy years and years ago, right over here, and it was they were having a party at their house, and it was I won't forget this call, but so we get there, and it was for someone not feeling well or something. We get up there, and the guy's outside on the front porch, and he didn't even look like he was in any distress. And so we're like, well, where's the patient? And so he ends up, he's like, oh, it's me. And I'm like, okay, so what's going on? He's like, yeah, I just don't feel good, and I'm starting to get a headache, whatever. So we're like, we start walking him to the ambulance, and he's like, man, I really don't feel good. I just don't feel good. So we get him in the ambulance, and now he's like really agitated, man, he can't sit still, is all this, and yeah. So we take his blood pressure, and it literally went all the way, pinned on the blood pressure cup. We couldn't even get it. It was like 300 something.
Holy buckets.
And then the bottom number was like 280. It was crazy, and he's freaking out, and we stuck him, because we're like, what is, what's going on? So we stuck him, and literally the pressure from that shot from the gurney all the way to the window of the ambulance shot out, literally like a rocket,
Wow.
like a squirt gun. And we're like, what? He ended up dying. And he was like 50 something. It was just like this crazy,
oh my gosh.
stroke that he had. I don't know how it was like that fast that he,
Say, Brian.
Well, and well,
what are
think
you
about
gonna
it,
do, you know?
So he was sitting there, he was somewhat relaxed, heart wasn't overworking, and if he got up and he walked himself to the ambulance, the heart started pumping faster, which probably caused the increase in the pressure of the bleed in the brain, and yeah, that's wow.
Yeah, I've never seen it that high on the blood
No,
pressure
I haven't
thing.
either.
It was like it literally was pinned, and you just heard it going, So
I would be curious at some point in my career to find out what's the highest blood pressure someone has ever gotten.
yeah, I had.
Yeah, the only highest I've ever seen it is 240. That was it.
I'm sure no matter what.
That was the bottom number was like 280.
That's
That's
incredible.
yeah.
I'm sure no matter what the highest you've ever seen or heard, we have someone who's seen a little bit higher. I won't name names, but
Yeah, it's not me. I did see it though.
Not you.
I know.
You know what I'm talking about.
Yeah.
Jeez.
Yeah. It's different.
Yeah, well, and, you know, and think about it.
400.
That would have been some guy you've been like, wow, give him some nitro, reduce some of the pressure. Some of you guys that have been around a long time remember the Procardia, which was a little gel cap and you used to poke it and squeeze it underneath your tongue and it just dropped their pressures. That's the big thing with pressures. I mean, that bad was, there's nothing you can help with that one, but you know, some people try and want to drop that pressure so quickly. Well, the brain's perfusing. We want to do it slowly. They'll give Labetalol or something to that degree in the hospital to slowly reduce the blood pressure. And they can't give TPA to someone whose pressures are up that high either. So, but wow, that's incredible. Now, if you're going to go ahead and intubate someone and use your drug-assisted intubation, do we use the lidocaine? Yeah, if we see neurological deficits and we're suspecting that this patient may have a head bleed, we do want to go ahead and administer the lidocaine. We don't want that pressures to go any higher. Again, as I've told you guys time and time again, there is nothing for or against lidocaine to say it really does anything. Our system, most systems have actually taken it out. We haven't quite made the jump yet. We'll see what happens this year as far as whether or not we remove the lidocaine. Giving the etomidate, 0.3 milligrams per kilo to a max of 20. And then one thing, and I keep going over, I still hear complaints. So you're getting ready to intubate someone. Remember, etomidate doesn't last that long. So get all of your equipment ready to go. The person who's pushing the meds, have their meds. They should have the etomidate drawn up, and they should have the first dose of Versed drawn up. Both of them ready to go. So, person who's getting ready to intubate says, all right, I'm ready. Etomidate gets pushed, count to about 10, and then you should be able to start your intubation. If you're waiting longer than that, you're probably going to go ahead and lose the effects of the etomidate after about 30 seconds to a minute. As soon as you've got the tube, you've verified tube placement, and you're getting ready to secure it down, listen to lung sounds, end titles on, push your Versed right away. And I know it says here, for post-intubation sedation, we want to make sure that we're keeping them sedated. We don't want them waking up. If you take a look at your capnography, you'll see that cleft plateau. You know, it comes along and then you see a little dip in the plateau. That means that the patient is kind of starting to fight the tube. So go ahead and give them Versed right away. 2 milligrams over 2 minutes, up to a max of 20 milligrams for these patients. So you want to keep them out. Versed should last maybe about 15 to 20 minutes, but you know, you might need a little bit more depending on the size of the individual. And then just make sure you're monitoring your capnography. Keep it at that low end of 35. Here's some of the different types that they teach for community education. We went through BFAST and FAST. There's another one called FASTER. And that's, again, it's face, arm, stability. Are their balance off? Are they able to talk? Their eyes, and how is their reaction? You know, calling 911 as soon as possible. So where do we take these patients to? We've determined they're having a stroke. There's a couple different types of stroke centers. First, you have what we call acute ready stroke centers. Most of these are comprehensive EDs that can handle, they can maybe do that first dose of TPA, but that's really about it. They're used to mainly diagnose and start the treatment of strokes. Then we have what we call primary stroke centers. Everybody in Region 10 is a primary stroke center. These patients, again, they can use to diagnose the stroke. They can start treating the strokes at the primary, but if the patient needs some type of intervention, then they need to go to a comprehensive stroke center. Now, we have no comprehensive stroke centers in Region 10. Everybody is a primary. Back in, I think it was like 2012 or 14, can't remember exact date, but the law passed that says you will bypass one hospital to go to a primary stroke center. And the state came down and says, all of you regions get together, put stroke plans in place. Region 10 really never did that. We finally had a stroke committee for Region 10, but the reason we didn't do it is because we're all primary stroke centers. It's not like we're Chicago, where you can bypass 5 hospitals before you get to a primary stroke center or a comprehensive stroke center. So what we're really looking at, so if you go stroke enabled, primary and comprehensive, you know, with that EMS, yes, EMS, we have to do the types of trainings for primary and comprehensive. Do they have on-site neurological? Yes, they do in both the primary. Do we have ED stroke protocols? Yes. Imaging, 24-hour CT, yes. MRI, 24/7, has to be in a comprehensive, but does not have to be in primary. The other thing is, can they do TPA? Yes. Do they have endovascular therapies? This is where your comprehensive comes into play. Your interventional radiologists. Interventional radiologists are very few and far between, and they're very expensive to employ within a hospital. And most of them will be part of various hospitals just because of the fact that there's so few of them. So determining where they need to go. So if we take a look here, primary stroke centers are all listed here, and all the ones with the double asterisk are within Region 10. Illinois Masonic, okay, the double ones are St. Francis System, the single ones are Region 10. Comprehensive, Lutheran General, Northwest, Northwestern, Central DuPage, Rush, University. Now, where is Evanston here? Evanston Hospital. Evanston Hospital is unique. Evanston Hospital is endovascular ready. They are not listed as a comprehensive emergency stroke center, so by law, we don't take patients to, if they're not to comprehensive, bypass one to go to a comprehensive. They haven't gone through the whole survey, basically, but they are endovascular ready. We're actually, I was talking to Joanne, our stroke coordinator, and I said to her the other day, I said, you know, when I'm teaching these guys, can I have them go to Evanston if they think it's a large vessel occlusion or they're going to need endovascular therapies? Because of the fact that they do have that capability there. Or is it because they don't have the actual accreditation, they're not included? And unfortunately right now, because they don't have the accreditation, they're not included in this comprehensive stroke center. But I will tell you guys, they do have the ability. And if you have someone with large vessel occlusion, they are truly better to go to Evanston than going to St. Francis or Highland Park or Skokie or Glenview, okay? Keep my job as I say that there. So, other things, they had mobile stroke units, Northwestern and Rush. I think it's Superior owns the Rush one. I can't remember, but Superior is with one of them. But we have these two units that actually have CT scanners in them. And they've got some statistics here, let me go. So Central DuPage's outcomes, they've been doing it for 14 months. They've responded to 450 stroke calls. They've reduced the TPA delivery time from 82 minutes to 52 minutes. They're trying to get to under 40 minutes, and a lot of that comes out, you know, with how soon they get on scene. Now, how they're dispatched simultaneously. So in Central DuPage, if one of their fire departments goes out on a call that they believe might be a stroke, they will go ahead and respond with them. So they both only operate 8 a.m. to 8 p.m. They operate 7 days a week, 365 days a year. And they cover the areas surrounding the hospital. And they do go with the fire departments. They have a CT scanner on board, and they're trying to go ahead and get TPA on board sooner. But remember, a lot of these patients don't qualify for TPA. You know, if they've had a stroke in the past, or TPA in the past, or they've had some type of injury, or been in an accident, been to the dentist, there's a lot of things that will disqualify them from getting TPA. They have a paramedic driver, a critical care paramedic, a critical care nurse, and a CT technology person, the CT scanner. and then they connect to a neurologist via telemedicine. So those are the 4 people that are on board. They'll get the patient on a CT right away. And then once they get back from the neurologist that it is a, not a hemorrhagic stroke, they'll go ahead and administer the TPA. TPA is very expensive. TPA is about $5,000 a dose if it hasn't gone up. So we go back to some of here, the different types of treatments, and I'm just going to show you some of these. So we'll start with.
Activase, also known as recombinant tissue plasminogen activator, or TPA, is the only drug approved by the FDA for treatment of stroke. Growing plaque can rupture, promoting thrombus formation by activating the coagulation cascade. Platelets and red blood cells aggregate at the site of injury, causing further narrowing of the artery. This impedes blood flow even more and causes turbulence in the artery. It also increases the likelihood of thrombus formation. As the thrombus grows, it causes increased vessel narrowing, leading to partial or even complete occlusion. The occluded artery leads to ischemia and tissue necrosis. When a piece of thrombus breaks off, it's called an embolus as it travels up the artery. During a stroke, ischemia can progress to infarction. Beyond the infarction lies still viable tissue called the penumbra. Cells within the penumbra are potentially salvageable if blood flow and vital oxygen are restored promptly. The penumbra is the focus of fibrinolytic treatment. Now let's look at the thrombus itself. Inside the thrombus are strands of fibrin, the protein that forms a clot. Enmeshed within the fibrin is plasminogen, the inactive precursor of plasmin. Activase is administered by IV infusion within 3 hours of acute ischemic stroke symptom onset. Activase binds to the fibrin in a thrombus and converts plasminogen to plasmin. Plasmin then breaks the strands of fibrin and dissolves the clot. As the clot dissolves, blood flow is restored, and viable tissue may be reperfused. Although the original infarction remains, when surrounding cells in the penumbra are saved or reperfused, function may be restored. Activase, the one TPA for stroke, is the only drug approved by the FDA for this indication.
So that just gives you a kind of a direction of how TPA actually works. Let's see. This is the one where they'll actually go in and break up the clot and suck it out. So a sheath will go into either the femoral artery or the femoral vein, or they'll use the radial artery or vein. And then this small wire will basically go ahead and go up and start to break up the clot. They do have the ability to turn on the aspirator, so anything that breaks off doesn't go flowing down further stream and cause another stroke. It actually will suck up the different parts of the clot as it breaks up in order to restore blood flow. This can be done up to 8 to 12 hours after signs and symptoms actually start to go ahead and increase flow back within the brain. And there goes the rest of it there. Turn the aspirator off, and then they'll literally pull the sheath right back out. This last one is the coiling. Dr. Ahuja from St. Luke's Medical Center actually is the one that did this one, or came up with this procedure. So again, they have a sheath in place with a wire coil. They poke it through the top of the clot, and then we have it kind of coils up. And then this coil wraps itself around the clot, and they pull it completely out. so that nothing ends up going past. And then they'll just kind of suck it right into the sheath there, or pull it right into the sheath. So they've got the whole entire clot. And they bring down the balloon, and then they pull the sheath completely out. Again, with that type 2, the last two, the penumbra and the Mercy clot removal, those are mainly used for the large vessel occlusions. TPA, we use it for anything that we might think is has some type of thrombus. And again, remember, amniotic fluid or air is not going to be cured by the TPA. You have to have something with the fibrin, the blood, the thrombus itself. So some of the things we worry about after someone has a stroke, they're going to be on long-term medication. Depends on what their history is. Do they have a history of AFib? Do they need to be on some type of antiplatelet or anticoagulant for long term? What other type of medications might they be on? We give them different education, but they've got to stay up on the education. They've got to be part of their plan. You know, a lot of times we discharge people home and they're not necessarily compliant in their own care. And so we do see people coming back to hospitals having further strokes if they're not being compliant. There's a lot of different support groups that people will use. So other things to take a look for: do they have diabetes or hypertension, heart failure? Those are some big post stroke problems that they may have. Do they suffer from depression? Are they able to manage on their own? They're not living the life that they were living before, so are they being taken care of? Do they have some type of therapy? Are they on antipsychotic medications or antidepressant medications? Other things to look for: urinary tract infections, limb pain. They have that phantom pain, they can. If they can't go ahead and swallow, do they have to have a G-tube in place? Are they having choking issues? Do they have problems with aspiration pneumonia? Those are things that people will suffer from. So they get about 11 different types of medications when they get discharged from having a stroke. They're going to be on antiplatelets. Most of them are glyco-2,3-BA inhibitor, which is like a super aspirin. It makes the blood slippery. Then they'll be on some of, spelling error, anticoagulants. And with these patients, these are that it doesn't allow the body to clot as quickly. They'll get antidepressants, antihypertensive medications. They want to keep the pressures down within the brain so that they don't go ahead and bleed and have another, with the vessels. And then there's anti-hyperlipidemia medications, statins, those that are suffering from high cholesterol. And again, you saw where that cholesterol kind of broke off, and that's when the body tried to repair it with the thrombus. So that is it. Anybody have any questions?
I had something off topic.
Yeah, go ahead.
Actually, I was talking with Tim about it in there, but Northfield had the baby call. Did they dispatch 2 ambulances right away?
Yeah.